Awesome. So I want to start by talking a little bit about epidemiology on how common diabetic foot infections are. I'm going to talk about the International Working Group on the diabetic foot infection classification, mostly because I think I've been on the working group for like 12 years. I don't think it's perfect, but it perhaps provides a common language. And then I'm going to talk a little bit about antibiotic treatment. Finally, I'll finish by talking about medical and surgical therapy, and then about the benefits of showing that you have a clean bone margin for clinical outcomes. So I'll reiterate what Dr. Snyder said. I mean, one of the things you have to understand is it's an impaired host, and there's on a number of levels. And so if you look at inflammatory markers, they live at an elevated level. I mean, if an orthopedic surgeon does a total joint and his SED rate is 25, they get upset. If someone has diabetes size 25, you're like, that's not a trigger for you. It's more like 60 or 70. So they have leukocyte dysfunction. If you rely on pain, they probably will have severe pain before it registers with the patient, and they have a variety of vascular challenges. So this is data from randomized clinical trials. So highly selected patient population. These people generally have an ABI greater than 0.7. This is kind of the standard. You kick everyone out that has end-stage renal disease or wounds that have been present for too long. So if you look at these people, the control arm in this column is on the right. So, and some of these are relatively well-known studies, the Dermgraph and Applegraph clinical trials, but a third of the patients in 12 weeks were treated for infection. Usually significantly lower in the active treatment arm, probably just because of exposure. They heal a higher percentage and they heal them faster generally. And then, those people have in 12 weeks, 16% of the people have some level of amputation. So in the Wagner 1 garden variety patient who's probably healthier than most patients, it's a considerable burden. This is data from a disease management cohort in San Antonio a long time ago now. So you look at 15% of people over 2 years to develop a foot ulcer. Of those patients, or had a foot wound, I should say, 61% developed an ulcer. So different than the first set, these are longitudinally followed. It's not a defined time period. And 20% of those people developed osteomyelitis. If you look at hospitalized people, it's the opposite. 67% of people admitted to the hospital have osteomyelitis, as opposed to 20% in the outpatient setting. So how should we classify diabetic foot infection? This is old. This is some old data. We've updated this in 2023. Every 4 years, we update this. So it's a living document. The classification has changed, and I want to share with you how this has changed. If you go to just type in IWGDF, you can get the documents for free. You can download them for free. You can get slides of the classifications for free. So and actually, I think you can get them in a couple languages now. So it's really meant for documents to be shared and used. So this is so my animation's a little off. So this is a 4-level classification system. No infection, mild infection, moderate infection, and severe infection. What has changed since we started was the definition for severe infection and then the addition of osteomyelitis in this classification system, because it helps present recurrent infections and resource utilization mostly. So kind of what Bob just said, none of these are based on a culture. They're based on clinical signs of infection, which I think is interesting because this was designed by a group of people that know that you have a bad host that doesn't mount a normal inflammatory response. So you should have greater than 2 local signs of infection, and the wound should not extend to fascia or capsular bone. The difference between mild and moderate is more than 2 centimeters of cellulitis, and it penetrates the deeper structures. So for those of you who have been on a consensus panel, a lot of this, I think, the most important decisions are made at midnight after the second or third scotch. And that narrows out all the wavy misunderstanding. The severe definition of severe infection initially, so there's been a change. The initial diagnosis was based on this potpourri of local and systemic signs of infection: fever, chills, tachycardia, hypotension, confusion. Not very well defined. I don't know how my little red thing got there. So now it's similar. Mild infections are the same, exactly the same. Moderate infections are the same. What's different? Well, what's different is severe infections are now based on SIRS criteria, systemic inflammatory response syndrome, which is one of 4 criteria. We wrote a paper a couple years ago, it was published in Clinical Infectious Diseases, that show this doesn't make any difference on outcomes. People that are really sick have a similar outcome, similar duration of antibiotics, similar reinfection rate as people that have moderate infections, because I think probably because you have a bad host. And it may even be better if your host is healthy enough to mount a normal response to a deep abscess, but that's a different story. The other thing that has been added, so this has been here since 2017, I think. What has been added recently is, what do we do with osteomyelitis? Clearly, people that have osteomyelitis have worse clinical outcomes. They're more likely to have a reinfection. They're more likely to have an amputation in most clinical studies. So what they did, so we had a little discussion about SIRS criteria. Dane Wukic has a paper that says it makes a difference in clinical outcomes. I have a paper that says it doesn't. We published a paper about the old classification that doesn't have severe or doesn't use SIRS with the old criteria. And other than that, a lot of this is just personal experience, and other people in the writing group have now published papers on SIRS. So the next addition was, if you have a moderate infection of osteomyelitis, now you add an O to the classification system. I think what needs to happen is you need to get rid of severe. You need to have a separate category for osteomyelitis, because it drives your decision making, it drives your utilization, and it probably drives clinical outcomes. So what's interesting is infectious disease doctors never measure peripheral vascular disease. They don't separate out other important risk factors. But if you make it too complex, people will not use it. So what's the best antibiotic for osteomyelitis? So Tony Barrett is a Cambridge ID doctor, and this is, let me see if I underlined this. I didn't. So what he said was, a recent systematic review disseminated the poor evidence based on making any recommendations on antibiotic therapy for diabetic foot osteomyelitis. No antibiotic is superior, because you need to take a culture and have your treatment tailored to the pathogen in the wound. It's not, rocket science. So empiric therapy, you need to know what pathogens are in your area. In Texas, MRSA is about 50%. In our center in Dallas, it was 8% of diabetic foot infections. But also, we're close to the border. People can go to Mexico and buy any antibiotic they want. And in Dallas, especially in Mexican neighborhoods, there are little pharmacias where you can go, to the neighborhood guy and get antibiotics over the counter, and a whole bunch of other, things that are not FDA approved. So a lot of people have already dosed their antibiotic for a long time and have established their own resistance patterns. So you should really pair your pathogen with good cultures and look at pathogens that have good bone diffusion. I'm not going to go through this, but if you look at these are the recommendations from the International Working Group. What's interesting is, if you look at other countries' recommendations, they're completely different. In France, rifampin is like the second thing on the chart. Not used very often in the United States, although there's a VA study that is evaluating that. So what you have to understand is, especially if you're making empiric therapy choices as an outpatient, you are not going to cover everything with a single antibiotic, probably. I see lots of people in the community that are being treated with doxycycline, like that is an awesome drug. So this is clindamycin. This is the gaps in clindamycin treatment, right? Same thing, if you're going to take Bactrim, you're going to miss this area of the spectrum, and everything has its deficits. So, consider this when you make your choices, because just giving someone an antibiotic is not what you need to do. These are antibiotics that have good oral bioavailability. One of the ID guys I work with gave this to me. I can't find any of this in the literature. So this is a study from Eric Senneville. He's an ID doctor from France. If you notice the literature, it's super small studies. Like, these would be okay for preliminary data for an NIH grant. Look at everyone else's literature, maybe not. If you go across the hall today, look at some of the vascular surgery literature. They're at least in the hundreds. So the other thing is, they exclude most of the people that I see with osteomyelitis. So if you don't have a palpable pulse, you're out. If you have gangrene, amputation of bone excision, or if they think you're going to need an IND, you're out of this study. So these are people that have chronic osteomyelitis that they have the luxury of stopping their antibiotics for 2 days because they're afraid if you have antibiotics, it's going to ruin your culture results. Maybe Andrew will talk about that later. So in this study, this was a retrospective study, people that had antibiotic-directed or pathogen-directed antibiotics did better. Common sense, right? This is the only paper I can find on this in the diabetic foot. How about the duration of antibiotics? Big debate on this. There are no stopping rules that ID people routinely use to go, you know what, your CRP is normal, we can stop now. If someone had breast cancer, you wouldn't go, you know, you're getting 6 weeks, and then go with God. I mean, they are monitored. We don't, my ID people are like, you know, you got 6 weeks. Talk about mythology and old wives' tales. It's still, so this has been kind of the model for the International Working Group and the IDSA for a number of years. It depends on if you have no resection of bone, if you have partial resection of bone, if you have complete resection of bone, the duration of antibiotics they recommend. This is midnight after the second scotch timetable. There's no evidence for this. Now there's a little bit of evidence. But right now, no one follows any of those categories. So if you look at these, first of all, the success rate is kind of all over the place. The best you're going to do is about 80%. And a lot of their definitions for success, I think, are ridiculous. The studies are small. The duration of antibiotics are crazy and all over the place. And there's a variety of drugs that are used, probably because a lot of people are still using antibiotic-directed drugs. There's a growing body of work that suggests oral antibiotics are as effective as parenteral antibiotics for osteomyelitis. And you'll probably see more of this. There's at least a couple studies planned in this space. So again, a retrospective study showing this. So 2 studies, Eric Senneville's group in France compared 3 and 6 weeks of antibiotics for people with chronic osteomyelitis. No one with a deep infection or associated abscess. And then the study with similar parameters were repeated comparing 3 and 6 weeks of antibiotics. No difference in 6 to 12 weeks, no difference in the success rate of 3 versus 6 weeks. And in both of these studies, the success rate was reinfection. Sometimes the ID people have wound healing or development of an ulcer or having an amputation, no matter what the cause. So maybe 3 weeks is as good as 6 or 12. What about medical versus surgical therapy? So it's not always a choice. Someone comes in with an abscess, you don't go, well, we're going to opt for oral therapy. If they exposed bone or ascending cellulitis or a gas infection, you're not going to wait for them. You're probably not even going to present just medical treatment as a choice. So it's not often we can sit here and wait. Maybe people that have chronic osteomyelitis like Eric Senneville has, maybe that's the case. So this is Ben Lipsky, an ID guy who's been on the panel for a long time. So what does he say the reasons for non-surgical treatment? Patient preference. Sure. I mean, I think one of our jobs is to present the information and let the patient make a decision. Surgery not required to deal with the adjacent to soft tissue infection. You know, a lot of people come in with cellulitis. You don't think they have a deep abscess. Sure, I think IV therapy or oral therapy may be the way to go. No persistent sepsis. 60% of our patients admitted into the hospital don't have sepsis. So this doesn't apply to everyone. Patients who are too high risk to have surgery. We do almost all these people MAC. Our risk of anesthesia is really, really low. And sometimes the people that are really sick, they just have to go anyway. So what's the comparison of medical versus surgical treatment? Usually we don't improve anyone's biomechanics when we cut off part of their foot. We usually, just push the dominoes and try to deal with the consequences. I was trained that you have to excise all the bone infection, then we'll deal with what is left over. And that may not necessarily be the case. So I think the biggest thing is these people are at high risk of having an ulcer because they already have damage to their tissue. Biomechanics doesn't really change. So again, this is the medical treatment. I'll show you the data for the surgical treatment. There's now one RTC in this space that compares medical and surgical treatment. Again, they're not the people that you're gonna be called to see in the ED probably with an abscess. So the success rate is in the upper 80s, not really able to compare groups. So this is what we had. This is an old study, retrospective study, 35 and 32 people in each treatment arm. No one's gonna get too excited that is a great big study, but this was published in Diabetes Care 30 years ago almost. Significant higher rate of healing, lower duration of healing, lower antibiotic exposure, less need for additional surgery in this study. So in this RTC, let me go, I'm sorry, this was, no, that's not him, there you go. This is a randomized clinical study from Spain where people got medical treatment or surgical treatment, and you can see primary healing, no difference. Time to healing, no difference. Minor amputations, no difference. And this is like the best science we have. Let me see if I had also a very small study, less than 50 in this study. And the last issue is, does complete resection of bone improve clinical outcomes? So there's a growing body of work. This is data from our group. It's a meta-analysis that was just recently accepted for publication. But if you look at the healing rate, reamputation rate, antibiotic exposure, reinfection rate, it all suggests that if you have complete resection of the bone and clean histology and cultures, that the outcomes are better. So significantly better healing rate. No, I'm sorry, no difference in healing rate. The risk of amputation was 4 times higher. Oh, come on, my slides. I'm missing a slide. But there's 2 new studies that aren't included in this. One is from 2022 that suggested clean margins were significantly better. What's interesting is at 12 months, the amputation rate was significantly better, but not at 6 months. I don't think your infection 6 months later or your amputation 6 months later probably has anything to do with your current or your previous ulcer and osteomyelitis. Readmission was significantly higher and antibiotic duration was significantly shorter if you had complete resection of bone. I think the antibiotic resection is complete, it's your bias. If you believe in this, you're gonna stop the antibiotics. Our ID people don't. Oh, you have a clean margin, great. Everyone's gonna get a long duration of antibiotics. And then this is our data from a paper that I think it should be online recently, where we looked at a large cohort and look at our reinfection rate. It was 25% and essentially overlap for people that had complete resection and residual bone infection people were admitted to the hospital for moderate or severe infection. No difference in the wound healing rate. Wound healing trajectories are essentially overlapping. So I think ours is the only study that says there's no difference. And there's no difference in reamputation, antibiotic duration, same. So this would be published in International Wound Journal, I think in the next month or so. So, and this just shows that the similar data. Healing rate, time to healing. The only difference was people that had an amputation at their index hospitalization, or amputation was more common in people that had a clean bone margin. That's one of the reasons why they get a clean bone margin. So I think really simple take-home message, get a bone culture, direct your antibiotics with the bone culture. Oral antibiotics may be as good as IV antibiotics. The duration of antibiotics maybe depends on the bias of your ID guy unless you're making those clinical decisions. I think medical treatment maintains foot structure, but a lot of times our people have exposed bone. Bone is literally sticking out of their foot. You don't have a choice. You're not going to heal over exposed bone. And I think you should evaluate residual osteomyelitis unless you know for sure you weren't close to getting a clean bone margin. So with that, I will thank you and appreciate your attention.